start, sir. We are live.
Okay. Thank you. So very good evening, all respected doctors. I am Dr. Kunal Javeri from Zydus Medical Team. And once again, I welcome each one of you for such a scientific Sunday feast, and that is on a recent updates on bempedoic acid. And today's our topic is unlocking the recent updates on bempedoic acid and real world evidence from the Indian perspective specifically. And for that, we have a very senior eminent cardiologist from across the India. Today's our session will be based on a panel discussion. Initially, there will be a session by a very senior cardiologist, Dr. S. Manoj, and followed by we have a panel discussion with another senior cardiologist from across the India. And for that, I would like to introduce and invite our all faculties. So we have speaker Dr. S. Manoj, who is also going to moderate the session, who is a very senior consultant intervention cardiologist from Kaveri Hospital, Chennai, who is a proficient in...
Kunal, you can be brief so that we have time for our discussion.
Yes, I will be very brief, definitely. So he's a proficient in primary angioplasty and complex PCI and other cardiovascular procedures, and he is more interested always for the scientific sessions and dedicating 300 hours every month for doing all the scientific activities in national, international, program as well. With him, we have Dr. Bhupen Desai, who is a senior consulting cardiologist at Desai Heart Care Clinic, Borivali, from Mumbai. Dr. Jay Shah, who is a founder and member of Krish Heart Foundation and Krish Heart Clinic, who is associated as a senior intervention cardiologist at HCG Hospital, Ahmedabad, Gujarat. And we have Dr. M.S. Aditya, who is a senior intervention cardiologist from Yashoda Hospital, Hyderabad. And we have Dr. Louis Fisher, who is the chief intervention cardiologist from Director Cardiac Cath Lab from MOIC Medical College Hospital, Kochi. So without taking much ado, I would like to invite Dr. S. Manoj to sharing his screen, and we can start the scientific program. Thank you, sir.
Thank you, Dr. Kunal, and also thanks my co-expert panelists, Dr. Bhupen Desai, Dr. Jay Shah, Dr. M.S. Aditya, and Dr. Louis Fisher. Is a program where we would like to share the current update on bempedoic acid. 1 minute, let me start sharing. Yeah. Are you able to see in the presentation format?
Yes, sir. It is visible. Okay. Yes, clear.
So unlocking the recent updates on bempedoic acid as well as the real world evidence. These are some of the recent updates from our country by the ICMR INDAB, where about more than 113,000 individuals were screened to understand the metabolic conditions, the metabolic disorders that they have, both in the urban as well as the rural. You could see that there is a significant prevalence of dysglycemia, hypertension, abdominal obesity, and high LDL cholesterol across the rural as well as the urban population. Yeah, so metabolic conditions is growing significantly higher than what was previously estimated. And the prevalence of dyslipidemia in various forms is to the extent of 81% among the Asian Indian adults. So you would see the more common is the low HDL, and then the high triglycerides, high cholesterol, and the LDL cholesterol, which comes to around 21%. So dyslipidemia has always remained a major concern for occurrence of atherosclerotic cardiovascular events, and this is a very important study that we all know from Salim Youssef, published in 2004, the Interheart study across 52 countries involving 15,000 patients, and they found that ApoB 100 or high LDL levels contributed as significant, more important, and a very powerful risk factor for population attributable risk for occurrence of cardiovascular events. Now, these are some of the more important understanding in various clinical trials and also the Mendelian inheritance trails that naturally selected populations we have understood. So the meta-analysis of these three Mendelian randomized studies, the prospective cohort studies, randomized control studies unequivocally establishes LDL as a cause for atherosclerotic cardiovascular events. Well, if you take the randomized control trials, on an average, there's about a follow-up of 5 years, and they distinctly have shown that keeping the LDL to low levels distinctly remarkably reduces the cardiovascular events. If you see the prospective cohort studies like the Framingham and other cohort studies, the mean follow-up is at least 12 years, again showing a significant impact of low LDL in bringing down the cardiovascular events. A larger number of Mendelian randomized studies we have been followed up from the time they are born up to a mean follow-up of 52 years shows with nearly around 200,000 patients or subjects also indicates that making a low LDL levels reduces the risk of coronary heart disease. So from 5 years, we have a follow-up of at least 52 years showing distinctly that lower the LDL is better, and longer the lower LDL is even more better. And that is where the LDL burden comes in place, where to what extent the high LDL levels persist longer in the lifetime of the individual, conferring a persistently high risk, is what we have to target, not just a one-time reduction in the LDL, but it has to be sustained for the lifetime of the individual. And we have various interventions in the form of statins, bile acid sequestrants, niacin, CETP inhibitors, ezetimibe, and also the PCSK9 trials, which came later on. And with the addition of bempedoic acid, we have another pharmacological agent to add to these therapies and therapeutics to assist us in bringing down the LDL to lower levels. Now, these are the primary prevention trials, and all these trials have shown that the statins are the drug of choice for primary prevention of cardiovascular disease. There are a multitude of secondary prevention trials, again showing that statins are the drug of choice by significantly reducing to the extent of 33 to 52% in various trial subjects. So the prospective meta-analysis from all these 14 randomized trials shows that for each 1 millimole, which is around 39 milligram of LDL-C lowering, reduces the mortality, all-cause mortality by 12%, coronary mortality by 19%, myocardial infarction, coronary death by 23%, revascularization by 1/5, and 17% reduction in the fatal and non-fatal stroke, and 21% reduction in any major vascular events without an increase in non-vascular mortality or cancer. So these are very, very important understanding by each 1 millimole or 39 milligram per deciliter of LDL-C lowering. So more we reduce, more greater the reductions on these figures that we know. So this is a cartoon which shows that at any point of time, we initiate the statin or any lipid lowering therapies and bring down the LDL to very low levels and sustain, we would be able to retard the progression of or even the initiation of the first atherosclerotic cardiovascular event or coronary heart disease. So during the time of the individual, we possibly can delay the cardiovascular events up to the age of 80 years, which is fairly a long survival for an individual without an event or an event-free survival with the effective lipid lowering therapies. Now, currently, the best proven strategies, as we understand from various primary and secondary prevention trials for atherosclerotic cardiovascular disease, involves lowering and targeting LDL-C cholesterol. So what is the benefit of attaining LDL-C goal? As we know that the various subjects of dyslipidemia falls in various risk categories of low risk, moderate risk, very high risk, and also extreme high risk. The LDL-C goal differs from various individuals. And not only a 50% reduction should be achieved, but we should also try to reduce the LDL-C to lower levels. And this was tested in a Korean national weight cohort study with around 5,000 patients with a prior history of myocardial infarction. And they defined the LDL-C achievers as those who achieve a 50% reduction, more than 50% or 50% reduction from the baseline of the LDL, as also the absolute value of LDL should be less than 70 milligram per deciliter. If both these things are achieved, they were defined as having an LDL achievers. So they found that 94% of patients were on moderate to high intensity statins, and the LDL achievers were only around 22%. So only 22% of those who were on moderate to high intensity statin with a prior history of myocardial infarction could achieve LDL-C of less than 50% from baseline, and also an absolute reduction of less than 70 milligram per deciliter. Now, if both these are achieved, you would see the red where there is absolute reduction of LDL-C to less than 70 milligram, and also from the baseline there is more than 50% reductions in the LDL achiever group. You would see the cumulative incidence of major adverse cardiac and cerebrovascular events are very, very least of about 2.3 as compared to achieving only either of these reductions in the LDL. So it's even more tougher for us to bring down the LDL to less than 70 milligram, and also along with that to reduce the LDL from baseline by more than 50%. So the concerns before us is, despite statins being the first line of therapy for management of dyslipidemia, do all statin users achieve the LDL-C goals as per the guidelines of recommendations? So this is something that we constantly address in every patient that we treat with statin as well as non-statin drugs, whether they are able to achieve to the goal levels. Now, as the understanding and the trials and various results came out over the period of last decade, the ESC 2016, where you would see that the lower risk, moderate risk, and high risk, and extreme high risk, when it came to 2016 from 2019, the goalpost has significantly changed from 2016 to 2019. So as the cardiovascular risk increases, one need to reduce the LDL more and more. So you would distinctly see that in the moderate risk, previously it was 115, now it should be less than 100 milligram. The high risk group, which was 100, is less than 70, and the very high risk, which was 70, it is now less than 55 milligram per deciliter. With the Lipid Association of India being more stringent because of the Asian Indians having a higher risk, it is the figure quoted is around 50 milligram per deciliter, with an optional reduction up to 30 milligram per deciliter in the very high risk or extremely high risk group. So it's tougher and tougher for us to achieve these target goals with statins alone. So based on the revised ESC 2019 guidelines, there was a study from the Da Vinci to see how many patients have achieved the goal levels of LDL-C to the control. So the study showed that 50% of patients did not derive the recommended reductions to the base from the baseline with the statin therapy alone. So statin monotherapy is not alone sufficient to get the patients to the goal reductions of the LDL-C as per their risk profile. So this Da Vinci study, which is across 18 European countries involving around close to 5,900 patients, both involved primary as well as secondary preventions to the extent of 3,000 and 2,900 patients. They looked at how many of these patients among the 5,900 reached the LDL-C goal. If you see the overall study subjects in all statin users or monotherapy of statin, you would see that the reaching the goal as per the 2019 guidelines was just around 33% of patients achieved the LDL-C goal with a high intensity statin. Now, if you see a subset of analysis of those who received a high intensity statin, it was only 27.6% of patients who are receiving high intensity statin, and in that only 1/3 could achieve the target goals among that risk category. Now, further analysis of this Da Vinci study among the statin monotherapy usage in very high risk atherosclerotic cardiovascular patients who have an established cardiovascular disease, one needs to reduce the LDL-C to 55 milligram or lesser than that. You will see that only 37.5 patients could receive high intensity statin or could tolerate a sustained dose of high intensity statin for long term. And among that, only 22% of patients could achieve a LDL-C reduction to 55 milligram per deciliter as per the 2019 ESC guidelines, which would mean that 78% of patients receiving a high intensity statin in the very high risk category of patients do not achieve the LDL-C reduction, and this confers them very high residual risk. So the concern too is how to achieve the LDL-C targets after maximally tolerated dose of statin. You may not be able to always give statin in the recommended dose, but you have to go up to the tolerated statin. Even in a high intensity statin group receiving, a patient may be able to receive only a low dose of statin because of statin intolerance. So the maximum tolerated statin may not necessarily be able to achieve the LDL-C target in many of the subjects. So the ACC-AHA panel recommended clinicians for considering non-statin medications in the following high-risk group, where the individuals who have less than anticipated response to the appropriate intensity of statin. So while receiving an appropriate intensity statin, they're still not at goal, you consider adding a non-statin medication. And the second category is the individuals who are unable to tolerate less than recommended dose of or intensity of statin. For example, an individual who is at extreme high risk or a very high risk needs a high intensity statin, but he is able to tolerate only moderate intensity statin. That's not sufficient to achieve the LDL-C target goals. So you may have to consider adding a non-statin along with the statin therapy. And the third group are the truly intolerant or completely statin intolerant individuals, where even a low dose of statin may not be possible to be reinitiated in that individual. Now, the use of combination therapy of non-statin therapies along with the LDL-C has been noted to have an additive effect to reduce the cardiovascular risk. And this is seen in the IMPROVE-IT with ezetimibe and simvastatin and Fourier trial and the Odyssey trial, where distinctly you would see that there has been a significant reduction in the cardiovascular death, myocardial infarction, hospitalization for unstable angina, coronary revascularization over a period of 3 years to 6 year follow-up, as you could see in various non-statin trials along or added on to the statin tolerable doses. Now, this is a very important thing that we should keep in mind, where we know that the reduction in the moderate intensity statin is to the extent of 30% from baseline, and high intensity statin is 50% from the baseline. But if you combine high intensity statin plus ezetimibe, you could perhaps reduce the LDL-C from baseline in that individual by 65%. However, if you see the PCSK9 monotherapy by itself, in the absence of statin as a monotherapy, it can reduce to 60%. PCSK9 plus high intensity statin can reduce from baseline by 75%. And PCSK9, high intensity statin, and ezetimibe as a triple regime can bring down the LDL-C from baseline by 85%. But various registries, including the Sweetheart registry, shows that the PCSK9 penetration in the treatment of extreme high risk and those who need a very low levels of LDL-C reduction is only less than 1% among those who are eligible to receive the PCSK9. So we need an alternative to PCSK9 along with the high intensity statin and ezetimibe. So currently we have what is available is the first-in-class LDL-C lowering drug is the bempedoic acid, which is the ATP citrate lyase inhibitor, and it's approved in USA, European Union, and also India. And the approved indications are to reduce the uncontrolled LDL-C on the top of maximum tolerated statin therapy, and also those with mixed dyslipidemia, familial hypercholesterolemia, and those high-risk atherosclerotic cardiovascular disease subjects. The second category is the statin intolerant, in whom statin is, or those individuals where the statin is contraindicated because of previous events of rhabdomyolysis. So the dose is 180 milligram given orally with or without food, and is a single once daily doses. So the novel mode of action is that you would see the bempedoic acid inhibits the ACLV-L1 enzyme, and which through this enzyme it becomes an active drug, which is the bempedoyl coenzyme A, and this prevents the citrate from converting into acetyl coenzyme A, which is the initial step in the cholesterol synthesis. Subsequently, with the statin also acting on the HMG coenzyme A reductase, you would see that the cholesterol synthesis is markedly reduced, and the reduced level of circulating cholesterol, or LDL-C cholesterol, increases the expression of the LDL-C receptors, which are upregulated on the hepatocytes, and then there is a further reduction in the LDL-C from the circulating bloodstream. One important aspect of the bempedoic acid is this, the enzyme which activates the bempedoic acid to bempedoyl coenzyme A, which is the ASCVL1, is absent in the skeletal muscles, and therefore, unlike the statin, where the HMT coenzyme reductase enzyme is also present in the skeletal muscles, the bempedoic acid is bereft of any skeletal muscle or myalgia or any muscle-related side effects. So it becomes more tolerable. Now, there have been a stream of clear studies. The indications have gone through phase 3 programs where the clear harmony and clear wisdom were tried on the background of a maximally tolerated statin therapy. And the second group of clear serenity and clear tranquility were looked into patients who could not tolerate statin, or they were on very low dose of statin background therapy. Taking one by one, you will see that clear harmony and clear wisdom those are secondary prevention trials where patients either having atherosclerotic cardiovascular disease or heterozygous familial hyperlipidemia, or both, receiving maximally tolerated statin on which additional therapy of bempedoic acid was considered. And they looked at the LDL-C lowering from baseline up to 12 weeks, and also overall safety at a follow-up of 1 year. So you would see that there were subjects of around 2,230 patients in clear harmony, and clear wisdom had around close to 780 patients, and they were followed up for 1 year period. What you could notice is that from the baseline, persistent hypercholesterolemia, despite maximally tolerated statin therapy, when they received bempedoic acid over and above the maximally tolerated statin therapy, the LDL-C reduction comes down by close to 15 to 16%. And this is shown very clearly in the clear harmony and the clear wisdom. And there's a significant reduction, which you could see the p-value of less than 0.001. Now, coming to the clear tranquility and serenity, where they involved the subjects who were statin intolerant, bempedoic acid was added to ezetimibe, and in the clear serenity, only bempedoic acid was considered. And they were followed up again for a duration of 12 weeks to 24 weeks with 269 subjects in tranquility and 345 in the serenity. And they also looked at the safety at 12 weeks and 24 weeks of follow-up and the reduction in the LDL-C. Again, you would see that for those who are unable to take statin over and above the ezetimibe or bempedoic acid monotherapy alone, reduced the LDL-C by close to 23% from the baseline. So this is a distinct reduction of clearly by bempedoic monotherapy alone in many of the patients who could not take statins or intolerant to statin. Now, this is a phase 3 trial where ezetimibe, bempedoic acid were given in a fixed dose combination and were tried in against the placebo, ezetimibe monotherapy, and bempedoic monotherapy, and a group of patients who received the fixed dose combination of ezetimibe and bempedoic acid, and looked at the percentage reduction of LDL-C at 12 weeks. And you would distinctly see that 36% of patients receiving fixed dose combination of ezetimibe and bempedoic acid could reduce the LDL-C by 36% from baseline at 12 weeks. So a combination of bempedoic acid and ezetimibe can remarkably reduce from the baseline by 36%, even in the absence of statin therapy. And therefore, this could also add on to effective reduction in many of the patients who could not receive PCSK9. Now, does the bempedoic acid reduce inflammatory markers? Yes, distinctly in all these clear harmony, clear wisdom, clear tranquility, and clear serenity, you will see that the blue bar, which indicates that there is a reduction from the baseline more significant than the placebo for reduction in the hsCRP, which is an inflammatory marker. And the studies have shown the Jupiter trial that reducing the hsCRP has distinctly reduced the cardiovascular events. Now, the pooled analysis from all these trials, the 4 pivotal trials of phase 3, indicated that there were few side effects, and more predominantly it was hyperuricemia and a very, very minimal incidence of tendon rupture. And there were no worsening of the new onset or worsening of diabetes. So that was very, very clear that bempedoic acid had no adverse influence on the glycemic control, and hyperuricemia and gout are generally observed 3 to 4 weeks after the initial treatment, and later on is well tolerated. If the patient doesn't develop within the 3 to 4 weeks, it's unlikely that he would develop hyperuricemia related symptoms beyond that period. So a word about the tendon rupture and bempedoic acid usage. Its occurrence is about 0.5% and often manifested in the rotator cuffs of the shoulder, biceps tendon, and Achilles tendon. And the concern is about the patients above the age of 60 years and older, and those who have advanced CKD, those with previous history of tendon ruptures and tendon disorders, and also those taking fluoroquinolone drugs and systemic steroids for various other inflammatory or chronic vasculitis or other inflammatory rheumatism. So finally, let us come to the more important aspect of the clear outcome analysis. We certainly know that bempedoic acid reduces the LDLC levels from the baseline by about 15 to 16% on the top of statin, and by monotherapy it reduces the LDLC by around 26%, and with the effectiveness of bempedoic acid and ezetimibe, it can reduce by around 36%. However, whether these reductions of LDLC by bempedoic acid translates into cardiovascular outcome reduction is what was tested in the clear outcome, which was presented in the ACC 2023. So it involved patients with both primary and secondary prevention patients with LDLC, elevated LDL cholesterol, and those who are also statin intolerant. And mean follow-up was around 40 months and involved around 14,000 patients of phase 3 clinical trials and was matched with the placebo. So they were equally 1:1 randomization, 7,000 patients each in bempedoic acid 180 milligram per day and placebo at 7,000. And follow-up was at 1 month, 3 months, 6 months, and thereafter up to every 3 months, up to follow-up of mean follow-up of 40 months. And you would see that distinctly bempedoic acid and the placebo arm were equally, the demographics were equally divided. The age was 65 in both the arms, LDL cholesterol 139 in both the arms. The primary prevention subjects were 30% in both. Secondary prevention was 70% and 69.8, quite well distributed among the matchable demographics. The statin use was 23% in both the groups. Ezetimibe use was slightly more in the bempedoic group as well as the as compared to the placebo arm. So at a mean follow-up of about 40 months with a maximum follow-up of about 60 months, you would see that the four component MACE, which involves the myocardial infarction, cardiovascular death, stroke, and revascularization, was significantly reduced by 13% relative risk reduction. The 3-point MACE, which is the MI, CVA, cardiovascular death, and stroke, was reduced by 15%. Fatal or non-fatal myocardial infarction was significantly reduced by 23%. The need for coronary revascularization while the patient was receiving bempedoic acid was reduced by close to 19% relative risk reduction. And you would see all these parameters were with a p-value of less than 0.007, or even in some of the instances it was less than 0.001. So the clear outcome analysis of patients who are statin intolerant also showed that LDL-C cholesterol and non-HDL cholesterol also reduced by 34%. And it was very, very heartening to see that these reductions of 34% from the baseline by the bempedoic acid translated into 4-point MACE as well as a 3-point MACE, and also myocardial infarction as well as the coronary revascularization reduction significantly to alter the cardiovascular event profile in these individuals. Now, the clear outcome also indicated that in the safety analysis, serious adverse events leading to discontinuation were not different compared to the placebo than in the active treatment arm. The myalgia was also same. Renal impairment was also more or less same. What was distinctly seen was again the hyperuricemia, 10.9% versus 5.6%. However, the gout incidence was just about 1% more than the placebo arm. So the clear outcome study established our understanding that bempedoic acid is the first ACL inhibitor and also the first orally administered non-statin drug to demonstrate statistically significant reduction in the 4-point MACE events in patients who are at high risk of cardiovascular disease with a documented statin intolerance and also having elevated LDL cholesterol. So it is important that even if patients do not take, are not able to take the right intensity or recommended dose of statin, or those who could not take statin in any forms because of the true intolerance, bempedoic acid significantly reduces the LDL-C cholesterol as well as reduces significantly the reduction in the 4-point MACE in this clear outcome with a mean follow-up of about 40 months. So the best registry, which is the retrospective analysis, and I'm glad that many of the authors are here with us in the expert panel. It's the first real-world evidence of bempedoic acid on the efficacy and safety in the Indian patients who have uncontrolled LDL-C and while on statin and also at high risk of cardiovascular disease. About 140 patients were studied who are receiving bempedoic acid on the top of high intensity statin. 60% of patients were receiving atorvastatin 40 milligram, and the rest 40 milligram, 40% of these subjects were receiving rosuvastatin 20 milligram, and you will see that the baseline LDL cholesterol was around 140, and from 142 at 12 weeks, it was reduced to 106 milligram per deciliter with a change of about minus 23%. So in Indian populations on the top of statin at 12 weeks, we could see a 23% reduction from the baseline. And at 24 weeks, it was even more profound at 39% from the baseline reductions, or 33% reduction. So there was an added 10% more reduction with the continued use of 24 weeks of bempedoic acid 180 milligram from the baseline. It also translates into reduction in the triglyceride, total cholesterol, and also the non-HDL cholesterol. So there are multiple components of the atherosclerotic dyslipidemic fractions are also favorably affected. We wouldn't know the impact of increase in the HDL, which is obviously welcome at 7% increase in the 12 weeks and also 10% increase in the HDL. We wouldn't know unless we have a longer follow-up of this aspect of increasing the HDL by bempedoic acid. Also, we saw that at 12 weeks and 24 weeks, there are more patients achieving the goal levels. For those who need to achieve 100 milligram per deciliter, about 44% of patients achieved goal levels. Those who need to achieve 70 milligram, about 20% of patients achieved goal levels of 70 milligram per deciliter or less. For those who need a much more further reduction to 55 milligram, about 10% more over and above the statin therapy with the addition of bempedoic acid could achieve a goal level. So we are able to significantly enhance more patients with high cardiovascular risk subjects to reach the goal levels with the addition of bempedoic acid 180 milligram per day on the top of statin therapy as well as with ezetimibe. So the ACC consensus of 2022, you would see that if subjects are not able to achieve more than 50% reduction in the LDL-C, or the LDL-C cannot be brought down to 55 milligram per deciliter with a maximally tolerated statin therapy, you would probably may consider bempedoic acid or inclisiran, which is not available now. So bempedoic acid has come into the guideline recommendation through the expert consensus decision pathway of 2022, could add to the maximally tolerated statin therapy for those who need further reductions to achieve to their goal levels. So take home message, dear friends, the uncontrolled LDL-C is a major risk factor. Statins are the first choice of therapy for any type of dyslipidemia. Even after high intensity statin, about 70% of patients have uncontrolled LDL-C. Uncontrolled LDL-C increases the residual risk by close to 60 to 70%. Bempedoic acid is a first-in-class agent with a unique mode of action on the ACL inhibition, and it can achieve a significant reduction of LDL-C up to 18% from baseline as an adjunct to statin, and up to 28% reduction in statin intolerant as bempedoic monotherapy alone. It is safe in mild to moderate CKD patients. Hyperuricemia and gout are common adverse effects which should be monitored on regular basis, especially in the first 2 to 4 weeks of initiation. And bempedoic acid is indicated as an adjunct to diet and maximally tolerated statin therapy for those with heterozygous familial hypercholesterolemia or existing atherosclerotic cardiovascular disease that warrants additional lowering of LDL-C to the goal levels. The combination of bempedoic acid and ezetimibe is also indicated along with the diet management and maximally tolerated statin therapy to treat further elevated LDL-C to the goal levels in adults with the heterozygous familial hypercholesterolemia or also existing atherosclerotic cardiovascular disease who further require lowering of LDL-C. Resource-limited settings like our practice scenario in India, PCSK9 cannot be sustained for achieving LDL-C goal in many of these subjects that we clearly know of in our practice, and therefore the use of bempedoic acid in combination with statin and with add-on ezetimibe could achieve the LDL-C goals to many of our patients. And I would leave at this and thank you for your patient attention. We will take the discussions among the expert panelists on some of these questions that I would like to address to the panelists, and then we could have a very fruitful discussion. Kunal, can we go ahead with the panel discussion?
Yes, sir. Yes, sir. Yeah. Definitely.
Okay.
I think everyone has joined, sir. Yes. Yeah.
Okay. So we'll see how much we are able to discuss on various important aspects of dyslipidemia management and the challenges that we face. Let me address to Dr. Jaisha and Dr. Bhupan Desai about as per the 2019 ESA guidelines, how intense is the concern of uncontrolled LDL-C in our population after using statin?
Dr. Jay first.
Yes, sir. Good afternoon, sir. Yeah, I think it was a very nice lucid talk by Dr. Manoj regarding the uses of non-statin benefit group of drugs in a case of hyperlipidemia. As far as Indian population is concerned, I think we are coming across with so many young individuals. And young individuals means those who are in their productive life. And in those category of patients, like whatever may be the underlying condition, whether it is ACS, PCI, or maybe a unstable angina, where you need to target the LDL first. And as we are aware that as an Indian, we are being affected by nature and nurture both. And that is the reason I think we are having more of the coronary artery disease 10 years earlier than the Western population. So the problem is huge, and we must target LDL by using the best possible molecules like high intensity statin. And if the LDL target is not being achieved, then you have to add bempedoic acid and ezetimibe in all our patients, especially try and achieve those patients who are falling into the category of high thrombotic risk, because this is the risk where not only the antiplatelet will play a major role, but the statin will also play along with this other non-statin benefit group of drugs, which is going to give you a good plaque stabilization, because just by reducing LDL, you are just achieving the LDL parameter. But at the same time, when you are giving high intensity statin, you are very sure that you are going to stabilize the plaque. And once it is being stabilized, you are very sure that the non-culprit lesions, which are not being treated at the index event, they are also remain under control. And that is the reason I think the most important thing is that the patient should be kept under a strong follow-up, try and achieve the LDL in first 6 months, first 6 weeks. And more importantly, first 1 week is the area where you need to target the LDL at the with a very strong and very stringent criteria. That first index event, LDL in first 3 weeks, you have to target those LDL to the target as well as the goal level for that patient.
Thank you, Dr. Manoj, for a very comprehensive presentation. Excited. At least now we have some outcome data. Up till now we have that clear serenity and all those things. They only showed that it caused LDL reduction, but we were not sure of the outcome data. But now we have very elegantly presented that outcomes are also much better. It can reduce the reinfarction, mortality, stroke, and other things. So bempedoic acid definitely has a place in the treatment. I am very strong proponent of aggressive LDL reduction. And I go by Lipid Association of India guidelines. All my patients, I try to bring it to less than 50. All my high risk patients, very high risk patients, I try to bring. And it's very difficult to achieve only with statin. Statin tolerance is also a little issue in Indian patients. Most of the patients will not be able to tolerate the full dose of it. So in my practice, I add statin, which whatever dose patient can tolerate, then add ezetimibe, and as a third drug, I use bempedoic acid. And as you rightly pointed out, PCSK9 inhibitor is more of a theoretical thing in Indian setting. The data are very convincing, but people are not willing to spend so much of money and not willing to accept the injection. So we have a very good third drug now: statin, ezetimibe, and bempedoic acid.
Yeah, Dr. Aditya, could you share your views on this concern of uncontrolled LDL in our population, even after using the statins? And what do you think in your group, in your experience, how many patients are likely to achieve LDLC with or able to tolerate high intensity statin?
Yes, sir. So thank you for this opportunity to speak, sir. And it's a very elegant presentation. Are you able to hear me, sir? I'm having
Yes,
some problem with my phone.
Very clear. Very clear.
Okay, sir. So the issue is, I mean, three things have proven following this clear outcome data. One is, of course, the theory of lower the LDL, no matter how you achieve it, whether it's lifestyle, whether with a statin or with an add-on drug. And the strategy of lowering LDL always seems to work. So that is encouraging. So our cholesterol hypothesis is still holding. The second thing is my own experience of this drug with bempedoic acid is compared to ezetimibe, I feel the reduction in cholesterol is more predictable and more definitive, because what I'm seeing with ezetimibe in my practice is probably because of the Indian diet is quite different, or the mechanism of the drug itself is quite different. I was not seeing a very predictable and a sure reduction of LDL cholesterol. When I've started using this drug, bempedoic acid, I get a more predictable reduction of the LDL cholesterol. Now, the third point is, like other co-panelists have pointed out, that PCSK9, I've seen the reluctance. I tried pushing it. Maybe 1 or 2 injections people are able to afford, but then the whole year course and then what happens afterwards has been still a confusion. So we have now another adjuvant or a very useful tool or a useful modality wherein we can reduce the LDL cholesterol predictably, especially in these high-risk population where time is also a concern. Not only we should reduce the level, we should also reduce it in a quick time. So that way, I find it very encouraging, sir, with the outcome study data. And I think we should be using it in more for patients more effectively. My take is I would probably put this, with my experience, I would put this bempedoic acid slightly before ezetimibe also. So like I said, I was not getting a very coherent or a very clinical response with ezetimibe in most of the cases.
Yeah, I think it's well said that the strategy of how you reduce LDLC doesn't matter. As long as you reduce the LDLC to the goal is what really matters in reducing the events. Dr. Lewis, what are your thoughts on these challenges that we see in LDL reduction with statins and among our population? Is Dr. Louis Fisher there? So otherwise, we will go on for the next question, which is as per the 2019 ESC guidelines, what should be the ideal step to achieve LDLC target? Some of these have been already discussed now amongst us. Do patients able to tolerate high intensity statin for a long duration of treatment? Let me address this once again to Dr. Bhupen Desai.
Yeah, sir. As I told you, the statin intolerance is quite common in Indian patients. It is not only psychological. A good number of them complain of a lot of muscle pain and all this. We are not high body weight patient like Europeans and Americans. So to achieve a full dose of 40 milligram rosuvastatin or 80 milligram atorvastatin is sometimes very difficult. So I build it up to whatever dose they can tolerate, and then I add this combination of bempedoic acid and ezetimibe. But on a long-term basis, it's very difficult for most of patients to tolerate a very high dose of statin.
Yeah, I think you truly said the experience that we always face. Not many patients are able to sustain the high intensity statin. I suppose at least 50% or more of our population will be on moderate intensity statin or a low intensity statin because of various reasons. And the first thing that they come and ask is, can we reduce the dose of this? Because LDLC is lower, and also because they also don't tolerate with a lot of muscle. And with bempedoic acid being muscle neutral drug. It's predominantly affecting the LDLC cholesterol synthesis. It's a very additional benefit that we see, and the tolerance should be much better in the years to come during our practice. Dr. J, what are your thoughts on this?
No, I think I would agree with Bhupen sir that most of our patients, they will tolerate 40 milligram of rosuvastatin for first 1 or 2 months, but after that you have to reduce. So my usual practice is to give it for maximum tolerable months, preferably 3 months after the index event, especially ACS PCI. But if they are not, then at least 20 plus ezetimibe plus bempedoic acid. That should be the ideal way of by which we can keep it for a longer period of time, so that you can attain a good amount of LDL reduction.
Yeah, I think that's a very nice strategy, but maybe I could request the Zydus to bring a combination of ezetimibe and bempedoic acid. I'm not sure they already have it in market. So after the statin, we can just add one more pill with a combination of these two, which will make a very triple intensive therapy for lowering, rather than adding another sequence of initiation where the patients may not really feel that they are responding better. So in our routine practice, how would you approach the uncontrolled LDLC post-statin therapy, Dr. Aditya? I'll invite your comments again.
So, sir, this issue is very pertinent because either people are anyway Googling themselves what are the side effects of drugs, or they're convinced that they have body pains. So this is a bit of a problem. And another panelist has rightly pointed out that when they see their cholesterol reports, they just feel it has gone down too much. I keep emphasizing to them those guidelines, those cutoffs are actually not meant for them, not patients who already have heart disease. It's only meant for a primary prevention strategy. So I think we should also encourage the labs to not spell out these cutoffs, or at least add a disclaimer that these cutoffs don't apply to everyone. The other thing is the statin intolerance is a very genuine issue. I mean, especially 40 milligrams of rosuvastatin and 80 milligrams of atorvastatin, I see over a period of time, people do develop intolerance. They develop some body pains, especially people in the active lifestyles. I mean, somebody who is a laborer or somebody who's in a service, where a lot of travel is required. So, and it's a genuine problem, and we should have another armamentarium to achieve these LDL levels. True, sir.
So what do you think, Aditya, about introducing a combination therapy of bempedoic acid and ezetimibe as a second level on the statin therapy already the patient is receiving?
Yes, sir. So it actually is a very convenient combination. I mean, we have seen the results that 36% reduction in LDL is quite impressive when we give this as a combination, and this should be part of our usual practice, sir, to overcome so that we can lower the statin intensity, maybe a moderate or low level, and we have other drugs which have lesser side effects.
Dr. J, do we also agree that this combination of bempedoic acid and ezetimibe would be a most welcome combination amongst the practitioners in India, as compared to using monotherapy of bempedoic acid on top of statin?
Absolutely. And if I'm not wrong, there are 2 other companies. They've already got those combination. They're using it. We are anyway using it. I'm not sure whether they've come up with Bemdac EZ or not, but I think
there is.
Companies.
Zydus with Bemdac EZ.
Okay.
And several companies have combination.
Yeah. I think there are a few companies, they are already having a combination. So I think it's a welcome suggestion and welcome move from the companies, so that we can have a less pill burden and you can achieve a good LDL control.
Yeah, probably maybe we'll have to ask them to talk to the Lipid Association of India and say that the next step beyond the moderate or high intense statin should be a combination of bempedoic acid and ezetimibe before considering PCSK9, which is out of reach for many. I hope Dr. Bhupen Desai also would agree to that.
Yes, sir. Yes, I fully agree with you. I think, in my opinion, first we should give statin whichever dose the patient can tolerate. Second step should be the combination, not the individual. Combination of bempedoic acid with ezetimibe. And third step will be PCSK9 inhibitor, even after giving all these 3 drugs, if the lipid levels are not achieved.
Yeah, thank you for sharing that views. Jay, you have to add something more?
Yeah, I just wanted to ask one thing, that they are having combination of rosuvastatin 40 plus bempedoic acid as well. So by any chance, do you have that sort of clinical practice that straight away, if 40 along with bempedoic acid, which has been started, and what is the actual clinical scenario for those patients who are receiving it? Like I'm having very limited experience.
I don't think I have personally used a combination of both at one single point of time. Basically, the bempedoic acid currently has been added as a sequence to the existing statin therapy. So it could reduce further by, I would say, around 26 to 30% over and above the high intensity statin, and that's what the clear studies showed initially, where they were on heterozygous familial hyperlipidemia patients or atherosclerotic cardiovascular disease subjects. So you could achieve an additional from, I would say, high intense statin 50% plus another 76% you should be able to achieve from the baseline. And adding ezetimibe will bring it down to close to around 85%, which is the what you will achieve with the PCSK9, statin,
Correct.
and ezetimibe also. So we could keep the PCSK9 as a reserve in many of those who are not able to achieve the goals beyond this combination therapy. Dr. Louis Fisher, are you still there, or you're in a procedure? Probably, I think he's in a procedure. So I think this would be the last but one question. In routine clinical practice, how do you find the effectiveness of bempedoic acid to control LDL-C post-statin therapy? We've been talking about this. Anyway, let's give some final words on this, Jay.
No, I think bempedoic acid is a very welcome input from as far as the non-statin benefit group of drugs are concerned. Only thing is that there are 2 or 3 concerns. Sometimes when we use bempedoic acid, we have seen some mixed reactions as well. Like even though by definition and by mechanism, it should not produce any muscle defect or muscle related pain. But by adding bempedoic acid with at least 20 milligram of or maybe 40 milligram of rosuvastatin, we have seen a huge amount of muscle related toxicity. Now, whether it is contributing only because of the high dose statin or by adding this thing, I know that it is against the mechanism, but still we have seen a sizable number of patients. Those are having a very a peculiar a joint or the tendon related issues with bempedoic acid. And second is that we have to be little careful regarding the uric acid, because we know that hyperuricemia is one of the concern with bempedoic acid. Otherwise, it's only thing is that you need to keep a close watch. Number one. Number two, get the lipid profile at every 6 weeks at least, just to see that what amount of LDL reduction you are achieving, and try to ask the leading question to the patient. By and large, they will come up with the proper history that whether they are tolerating it well or not. I would like to ask the rest of the panelists whether they have seen similar sort of side effects with bempedoic acid or not.
Dr. Aditya, what are your opinion about this adding bempedoic acid and its tolerance in patients?
True, sir. So one is the effectiveness of bempedoic acid. I'm convinced, sir. We are seeing impressive reductions, and that seems to be there. Regarding my concern is with the hyperuricemia, definitely, as my co-panelist has suggested, because a number of our drugs seem to impact the uric acid levels. One is the diuretics sometimes that we use, and the second is we have seen with ticagrelor also somehow the incidence of gout goes up. And the third is this drug. So I would definitely be watching out for this uric acid business, because and some of our patients have CKD also. This seems to be of little concern to me, but so far it has not led to a situation where I had to discontinue the drug, sir. Regarding muscle toxicity, it seems to be lesser than, of course, the statin. People don't seem to complain as much with bempedoic acid as they complain with statins, sir. That much is my observation.
Dr. Bhupen Desai, sir, what are your opinions on this?
I fully agree that bempedoic acid is a reasonably good drug, but not as powerful as PCSK9 inhibitor. But for all practical purpose, I think bempedoic acid is much better as compared to PCSK9 in our routine day-to-day clinical practice. Whenever I start bempedoic acid, I always check uric acid first. As Dr. Aditya rightly pointed, many of our patients are on diuretics and uric acids are always on the higher side. So if it is on the higher side, then I don't use it. Secondly, I don't use it in a CKD patient. If the kidney functions are not up to the mark, I don't use it, because 70% of drug is excreted by the kidney. But I have a very silly question to ask you, sir, if you permit me.
Please
When
go
we
ahead.
when we use ARBs, we don't add ACE inhibitor, isn't it? So when you are blocking HMG coenzyme reductase enzyme, what is the point in blocking an enzyme upstream?
Yeah, I think that is because the blockage is not to the sufficient extent. It's not a complete blockage. So there is a partial blockage of that enzyme. It's not a rate limiting step. The rate limiting step in the cholesterol synthesis is the HMG coenzyme A. And that is why we need a downstream blockage with the statin. So the rate limiting step in the lipid synthesis or cholesterol synthesis is the HMG coenzyme A reductase. We just reducing the substrate for the HMG coenzyme A or the mevalonic acid which is produced. So the quantum of mevalonic acid which is occurring, which is transferred into the HMG coenzyme A is reduced. So that is where the supply of mevalonic acid is reduced by the use of this bempedoic acid. So that is the understanding about a dual blockage in the same sequence of cholesterol synthesis.
Correct, sir.
So I think there are alternate channels for the SL-CoA to enter the system, sir. So yeah, like sir said, I think it's a rate limit. I mean, it's not a rate limiting step. It might modulate or downturn it a bit, not totally.
So maybe that's the last. Considering the CVOT outcomes of bempedoic acid, how do you prefer to use in comparison with the other non-statin lowering of ezetimibe and PCSK9? I think we have been deliberating on this quite well amongst ourselves. There seems to be a very close agreement that we would prefer to use bempedoic acid and ezetimibe combination over a statin, or if the statin cannot be given as a first-line therapy, and then consider PCSK9 inhibitors. In fact, I had a patient who is a doctor himself. He's an ENT surgeon. He's had a 3 NSTEMI at various points of time in the last 12 years and has around 11 stents because he wouldn't prefer to have CABG surgery at any point of time. So he had a multivessel disease at various occasions. He has a heterozygous familial lipidemia. He was on statin. He could not do surgeries because of the cramps. And even the lumbricals and the thenar muscles go into cramps, so he could not hold any of the instruments. So he stopped taking statins, and that is the reason why he was getting recurrent NSTEMI, and though his LV function is normal, and then he had to go through multiple PCI procedures. So he was on evolocumab, Ripata, and twice a week he could adhere to that. He could bring down the LDLs to around 22 milligrams. Without that, it was around 160, 167. And after the introduction of bempedoic acid, once it came with ezetimibe, his need for PCSK9 has become once a month from twice a week. And he probably is now taking once in every 6 weeks, and his LDL-C still remains around 30, 32 in that range. So perhaps a combination of these statin or without statin, bempedoic acid and ezetimibe could reduce the frequency at which our patients may require use of administration of PCSK9. I suppose you all also may have a similar thoughts on such lipid lowering therapies.
Correct. Yeah. Very much so. In fact, some of the cases where I was really considering PCSK9, once this drug had come into market and started using, I could avoid in few cases, or I was not pushing them as aggressively before. So definitely it has made a difference.
Yes, the use of PCSK9 has gone down. After this Bemdac came into the market, use of PCSK has significantly declined.
But I don't think the cost has come down of PCSK9.
No, sir.
Yeah.
Some
Louis,
discount they're offering, but not fully.
Yeah. Jay, you have some final thoughts?
Just one thought that I need to give high dose statin right now to one of my patients who came with acute MI. So I'm going for a PAMI.
Yeah, take care. Thanks for being with us.
Thanks.
Yeah.
Thank you.
Dr.
Thank
Louis,
you.
are you still there with us? Otherwise, I'll hand over to Dr. Kunal.
Shall I take your leave, sir?
Yeah, please. Thanks for being with us. Yeah.
Thank you.
Yeah.
Thank you.
So I'll stop sharing here, and thanks all my expert panelists for their views and comments, which are very, very important, and message conveyed to the many other delegates and practitioners who would have logged in. There is something in the chat box.
Yes, sir. We have a separate link for the questions for the delegates, and I think there are many questions are there, but the two questions what I can hear we can present to everyone. The two questions are, first question is here what the one of the doctor from Hyderabad is asking that how much low for the LDL we can go. Matlab, even if it is a 20, as you said, one example of 22 of your patient is asking the same. There we should continue with the 20 milligram of LDL with whatever the measure. Is it right? And second, one doctor is asking that do we have any impact of non-statin drug like bempedoic acid on a triglyceride level? So these two questions to be addressed from our expert panels. Yes, sir.
Yeah, I think triglyceride also was brought down. All the trials, the clear series of trials did show triglyceride coming down. Even some of the data that I showed also had dropped the LDL, I mean, triglyceride by close to 22-23%. But currently, I think the focus from triglyceride lowering is moving away for atherosclerotic cardiovascular risk reduction as a major risk factors. The focus is more towards the still more effectively focused on LDL-C reductions, and triglyceride reduction is not much focused on in the recent times. How about Dr. Bhupan? What are your thoughts about that?
Yes, yes. All these drugs also reduces triglyceride, whether it is bempedoic acid or ezetimibe, but to some small extent. The major reduction comes in LDL, but they do have beneficial effect on triglyceride. And how low it should be, lower is the better. There is no downward limit. Lower is better. So theoretically, you can bring it down to zero also. In Fournier trials and other things, they have shown that people who had LDL of 15 or 20, they did not have any major side effect or any adverse effect or anything. So lower is better.
Aditya?
So, sir, yeah, the first question regarding how low can we go? I mean, that should not be. I mean, this is not like something like hypertension. People are afraid, how low can we go? Because hypertension does have a J curve, but lipid lowering does not seem to have J curve. Because the other thing is some genetically, some families in Italy and all, they don't seem to have. They have zero LDL and have almost zero cardiovascular disease. So we don't really seem to need this LDL cholesterol. So that part. I'm pretty clear. So the benefit on triglycerides has been pretty modest. A lot of the reports, because Indian dyslipidemia is typically having high triglycerides, people are more concerned about the triglyceride. But like you said, the outcomes with regard to cardiovascular disease are not as strong as that are there with LDL cholesterol. So I think the benefit in terms of triglyceride is modest. But then the other interesting, and I would also see that the HSCRP levels have come down. So inflammation is another target for cardiovascular disease, and this is a pretty impressive reduction. Because Indian patients are typically obese, they are hyperinflammatory, they are exposed to high levels of pollution, stress, and all. So I feel that anti-inflammatory property would be another interesting benefit from these drugs.
I think it gives an immense scope for us to study in our patients who have a lot of dysglycemia, and diabetic patients have also a pro-inflammatory status, especially in various vascular territories. And this would distinctly make an impact from what we understand about these molecules and its response in our system. And as regards the low LDL levels, one of the important slide that I presented was the naturally pre-selected the Mendelian traits, where the LDL levels are very, very low because they are born with very low levels. They have a single digit of LDL, and they live for 52 years of mean follow-up, and they don't have any events. So I think one message has to be very clear to all the medical practitioners that lower LDL levels are not harmful, and higher the LDL is definitely causing all the mishap that we see amongst the younger as well as not so young Asian Indians that we come across in our practice. That 30s and 40s is an age which is at high risk of cardiovascular events, and distinctly these molecules in a comprehensive way we could address the LDL lowering. Dr. Kunal, I suppose Dr. Louis Fisher is still not with us. He may be in a procedure. You could check with him.
Yeah, I think he's joined, but I think he must be busy in the practice. So I think with this, we have completed all the questions, and there was a very intense and depth discussion about the new molecule and the way out of the post-statin, how to control the LDLC. And on behalf of Zydus, we are very thankful for all the delegates who have joined for this program. And our special thanks to our all the panels and the speaker, Dr. S. Manoj, Dr. Bhupen Desai, and Dr. M.S. Aditya, Dr. Jai Shah, and Dr. Leo Fishkar for providing a valuable time. It is such a Sunday evening, though it's a relaxing time, but still you have joined for here and for almost, we are discussing on this topic for almost more than an hour. So thanks a lot for this particular discussion. And with this, with your permission, we can close the session, sir. Thank you. Have a nice day.
Thank you.
Thank you.
Thank you for the opportunity. Yeah.
Thank you. Bye-bye.
Thank you. Bye-bye.